All right, welcome back, everybody. We are hoping that we were able to fix everything. So I hear no echo. I hear myself. Everybody can hear me okay? I just need one thumbs up. Yes, thank you, Commissioner. Thank you. Love the thumbs up. All right. We are going to pick up where we left off. So thank you, Lauren, for sharing the introduction of our new staff, Brittany and Rachel. Welcome. Does not normally go this way, so there you go. Just to let you know. At this time, it is my understanding that we still do not have a quorum, so we are still reaching out to commissioners, but we will continue to move forward. So with that, let me continue with our announcements. We would like to remind everyone that we have posted 2 fellowship positions named after Sally Zinman and Rusty Selix. The peer consumer and mental health clinician fellows will apply their expertise and background to all aspects of the commission's work. We look forward to bringing these future leaders in mental health to the commission. So please visit our website or calhr.ca.gov to get more information. Also, we wanted to announce that we have new deputy director positions. We have 2 new deputy director positions available at the commission. The first is the deputy director of legislation, and the second is the deputy director of operations. To view more information on these positions, please visit our website or CalHR's website. And at this point, we are going to hear updates from our committees and subcommittees. I am going to invite Tom Orrick to please provide the CLCC update, and then Commissioner Zdanovich and Commissioner Tamplin to provide their committee updates. So with that, Tom, I would ask you to please start. And I'm
Great,
hoping.
thank you, Chair. Yeah, I'm happy to read Commissioner Alvarez's comments. The Culture and Linguistic Competency Committee met last week on October 18th. The committee was joined by the Commission's Prevention and Early Intervention Subcommittee staff, who presented the committee with an opportunity to engage in conversation and provide input on the second draft of the Prevention and Early Intervention report, Well and Thriving. We heard from both the committee and the public. The conversation we had was honest, insightful, and robust. We shared our thoughts, concerns, and recommendations while acknowledging current challenges in advancing statewide efforts, specifically the historical and systemic conditions that affect marginalized groups. The committee looks forward to seeing the revised version of the draft, and we appreciate future opportunities for dialogue around strategies, implementation, and how we can support PEI. The next CLCC meeting will be held on November 10th from 3 to 5 p.m. We'll hear a presentation from Commission staff Tom Orrock on the progress of the committee that the committee has made. As the year is coming to an end, we want to be transparent about the work that the committee has done, and in return, set ourselves up for success in future years. Thank you.
Thank you, Tom. I invite Commissioner Zdanovich, please, to provide an update.
All right. Thank you. So the following is an update on the Research and Evaluation Division. There were several presentations to tell you about, and also some development with respect to the Mental Health Services Student Services Act. So with respect to presentation, Xing Shen presented the Fiscal Transparency Dashboard work to other state agency at a Tableau gathering in Sacramento. And Dr. Martin Mollard was invited by the California Association of Local Behavioral Health Boards and Commissions to present at their quarterly meeting, where she solicited initial feedback on core metrics for school mental health. And with respect to the MHSSA, the team participated in a site visit to Marin County's Wellness Center and is planning to visit additional sites to help inform the evaluation of the MHSSA. And in the next month, 2 research scientist supervisor positions are going to be posted. These positions are going to help lead the MHSSA and the FSP evaluation efforts. And finally, looking ahead, we're scheduling a research and evaluation MHSSA work group. So this is a specific work group that's guiding evaluation efforts for the MHSSA on December 16th. And details of that meeting, which is going to be public, will be posted to the website and available for those of you that want to participate. That's my report, and happy to address any questions.
Thank you, Commissioner Danovich. Are there any? Seeing no questions or comments from fellow commissioners, I would ask Commissioner Templin, please, if you could provide your update.
Yes, of course. Thank you, Chair Madiga-Weiss. The Client and Family Leadership Meeting met on Tuesday, October 25th. It was great to see the members that attended and hear feedback during the general public comment period. The committee members and attendees, we have such a great group of people and with so much experience related to peer support and certification, which was one of our main topics of focus. Tom Orrick introduced an update to the peer certification resource guide, and we received insights and recommendations from our committee members as well as our providers and consumers. The committee has been gathering helpful resources to assist county behavioral health departments, CBOs, and peers in all aspects of certified peer support work. We hope to have a guide complete by the end of this year, so it's an ambitious goal, but we will get it done. Committee member Jason Robinson shared information on scaling peer services in California and made recommendations on how the state could incentivize peer support services. And lastly, we heard committee and general public comments on the PEI draft report, Well and Thriving, which was led by Stacey Hiramoto of REMCO. We heard that there should be a focus on college-age youth as opposed to just college students. In addition, we heard the report should specifically call out community-defined evidence-based practices as a strategy to reduce disparities. The feedback received will inform the Commission's decision as it considers adoption of the PEI report. And our goal for our next meeting will be to receive an update and input on the peer certification resource guide, to hear more committee feedback on PEI priorities, and to hear an update from CalMesa on the peer certification process, and specifically about any barriers that exist in grandparenting in the peer providers who were previously providing services in our mental health system. That's come up a lot in all our meetings, so we look forward to inviting CalMesa to present at our next meeting, which will be held virtually on November 15th from 1 to 3. And we also will be discussing application for the CFLC. So for any individuals that would like to join the CFLC and learn about that process, please join us on November 15th. Thank you.
Thank you, Commissioner Templin. I appreciate all the feedback. I watched the recording of the CLCC meeting. I plan to watch the recording of the meeting that you led as well, Commissioner Templin, and appreciate that we're getting additional comments and feedback, and we'll be meeting with the staff regarding the PEI report. And again, appreciate everything that we're learning and want to continue to move this forward. So appreciate your leadership with that. Commissioner Danovich, we have a lot invested with MHSSA, and so really looking forward to seeing what we design around evaluation. It is important for our feedback back into the school systems and really that intersection between mental health and school. So thank you so much for leading that up. With that, I also wanted to provide an update on the Children's Committee. We're pleased to announce that the Children's Committee is planning to meet on November 8th from 9 to 12. The meeting materials and more information are to come. Please check our website to stay updated. I also, regarding the PEI subcommittee specifically, the PEI subcommittee released the first draft of its project report on August 24th. The subcommittee met on September 7th and October 6th to hear feedback. Additionally, as mentioned, the Commission's Cultural Linguistic Competency Committee and the Client Family Leadership Committee discussed the draft. The PEI subcommittee will work with staff on the next revision of the draft. We're hoping to release the revised version for public review before Thanksgiving holiday. So please continue to visit the website www.mhsoac.ca.gov for more information. At this time, do any commissioners have any additional announcements that they would like to make? Okay, seeing none at this time. I wanted to lastly share that I would like everyone to know that through delegated authority, Napa County was approved to join the FSP Multi-County Collaborative Innovation Project. The project was shared with commissioners through the listserv, also with community partner, contractors, and the CLCC and CFLCC committees on 2 occasions, initially on 8/11/2022, and the final time on September 2nd, 2022. No comments were received during either sharing phase. Cody, please share the slide reflecting that approval. Thank you. Cody, I will say that we cannot read that slide at all. So I hope it's also in the packet. But yeah, that's not eligible. So please make sure, I'm sure that's in the packet. So, and we will do better with making sure that we can see those slides because I could not see that slide. Thank you, Cody. With that, I want to welcome everyone again to today's meeting. It was a rough start. So please, we apologize for that. We will continue to do better as we navigate this virtual world. I will remind everybody that we are going to do our best to end around 1 o'clock. Commissioners, if you leave the teleconference meeting for any reason and decide to rejoin, please make sure to use the raise hand function so that the commission staff can make sure that you are co-host again. If you have a comment to provide, please unmute your line and seek recognition when it is convenient. At this time, we are going to move on to agenda number 3, general public comment. This time is reserved for comments on items that are not on the agenda. If anyone is interested in making public comment regarding the announcements or other items, please make those during this general public comment time. If you have any technical questions, please contact us at 916-500-0577. At this time, I will ask Amariani to go over the public comment procedures.
All members of the public will have the opportunity to offer comment as described in the agenda. If you would like to comment on an agenda item, please wait until that agenda item starts. You may request to make public comment by clicking the raise hand icon on your computer or the app, or if calling in by phone, push *9. You will be placed in a queue to comment on that agenda item. When it is your turn to comment, the moderator will unmute your line and announce your name or the last 3 digits of your telephone number. When you are unmuted, we are able to hear you. We will do our best to take comments in the order they are received. Please note, once the public comment period for the agenda item starts, we will close the public comment queue, so please make requests to comment now. The moderator will insert the word last comment next to the commenter's name or number to identify the last public comment. Members of the public should be prepared to complete their comments within 3 minutes or less, depending on time constraints. When we have reached the end of your time, our staff will let you know, but we will let you finish your thoughts. We don't mean to cut you off, but we do want to help everyone keep time. We truly appreciate your understanding with this process. Lastly, if there are any members of the public using translation technology, please notify the chair and at least twice the amount of time will be given to you during the public comment period. A live meeting transcription or closed captioning is available for anyone participating in the meeting. If that option is not currently visible, please activate the closed captioning feature located in the control bar at the top or bottom of your screen. Chair Madrigal-Weiss, I hand it back to you.
Thank you, Amariani. Would you please open the line for general public comment?
Okay, we have first, we have 4 in-room comments. Richard Cornelius, you may go ahead.
Yes, and then just press the button.
Good morning. Thank you, Executive Director and the Commission members. Thank you for having us here today. My name is Richard Cornelius. I'm the president of the 100 Black Men of Sacramento. We have a lot of commonality between us, health and wellness, mental health. Just really here to introduce us and looking to work and collaborate with the great leaders of our city here and to really make a difference out in the community. Currently, and since 1986, we mentor youth at the middle school, at the high school, and we're proud to say that we just are starting a Collegiate 100 at California State University, Sacramento, Sac State. So a lot of services and programs that we put on and others that we work with. So again, really want to try to build a relationship so that we can work in the community and work together and make best for our youth, our parents, and the overall community. I was brought here, one of our members, Les Robinson, so go ahead and tell us why we're here.
First of all, thank you very much for having us. My name is Les Robertson, and my background is mental health. Retired from the Department of Corrections as a mental health counselor. I started a nonprofit named No Corporation, No Meaning Knowledge. And now I'm working with the 100 Black Men organization to provide mental health services for our community. Thank you very much for having me.
Go ahead.
Yeah. My name is Ricky Johnson. I am born and raised here in Sacramento. I am a 40+ year member of the construction industry, heavy highway. I am, my company is certified with the Department of Transportation, DGS, and I am part of the construction committee for the 100 Black Men to assist. And a lot of the federally funded project has federal funds in it for trainees and apprentices, notwithstanding, getting those folks through the training and apprenticeship programs to reach journeyman. We have a problem with our skilled labor to build California. So that's one of the aspects we'll be looking at through the Collegiate 100 and the mental health. And mentoring is something that helps people work through their challenges. We try to take the word problem out of the equation and call problems challenges so we can work on them effectively. And that's about what I got to say. Thank you for having us. All right.
So just lastly, we are part of the 100 Black Men of America. And so we have doctors throughout the country and in the Caribbean and in London. So we have quite a network. And I just like to leave and say, again, we know that you have different funding. And again, if we can work, you can help fund our services, our programs. And just proud to say also, we have just been nominated 2022-2023 Sacramento Kings Community Starting Five. So we'll again be working with the Kings and the community. And so let's just open it up and all work together. Thank you.
Thank you.
Thank you, Richard, Les, and Ricky. Appreciate that.
Next, we have Maya Bray.
Hi, everyone. My name is Mia Bray. I'm an intern with REMCO, the Racial and Ethnic Mental Health Disparities Coalition. As I'm sure many of you commissioners are aware, we've been scheduling meetings with REMCO and the California Reducing Disparities Project. And I really just want to express my gratitude today for every commissioner that we've been in contact with. And it's great to see some of you in person today. I specifically want to thank Commissioners Rolette, Gordon, Alvarez, and Cortese for meeting with us and having such great discussions around this topic. I also wanted to thank Commissioner Chen for being in great contact with us, as well as Commissioners Tamplin and Chambers for giving us the platform to discuss this item at the previous CFLC meeting. It was a great meeting. We felt very heard and supported, and we had some crucial discussions that were great. And we also have a few more meetings scheduled in November. So for those of you we have not heard from around these PEI priorities, we'd like to discuss a little bit more. And we are more than willing to have those conversations at any time that works best for you. We have a lot of people that work directly with the communities, as well as evaluators and stakeholders that would like to be a part of this conversation. And again, I really just want to thank the OAC. I am a graduate student and an intern, so I'm very new to this environment with policy and mental health. So I want to thank everyone for letting me be a part of the space and these conversations. So been a great experience so far, and I'm excited to keep going. So thank you all.
Thank you, Mia.
Next, we have Hector Ramirez.
Good morning, buenos dias, Hector Ramirez. I'm a consumer for the Los Angeles County Department of Mental Health. I am Native American, American Indian, Chiricahua, Apache. Hold up for the picture that the commissioner is taking. I am here, I haven't been here in almost 3 years. This has been a horrible, deadly COVID pandemic for our communities. And the inequities within the system really showed during that time. Our communities paid it, my tribe paid it, my family paid it. While we did advocacy trying to communicate with each one of you during the pandemic, those people died trying to be heard. 1 minute, 2 minute, 3 minute cutting off, the lack of accessibility, the lack of language accessibility for our community was paid dearly. They paid it with their lives. Our young ones are trying to commit suicide because of the lack of services in LA County, the lack of accountability, the lack of oversight. We have been demanding that our Department of Mental Health be transparent with their MHSA money. We have come to Toby, your executive director, for assistance. We never got information, yet we heard from the Steinberg Institute that there is over $1 billion of unspent MHSA money that could have been used to save the lives of our loved ones, and it didn't happen. And instead, that money continues to be utilized and allocated behind closed doors, behind stakeholder process, while some of the same organizations that get that money sit at this table. I asked today in mourning in recognition of the people that have died during this pandemic while trying to come here to each of you to ask for help, to listen to them just as much as you advocate for suicide awareness, to also have recognition of those circumstances that led for those people to die. Our Two-Spirit community is completely underfunded throughout the state of California and your initiatives. Our Latino community, which is the majority of residents of the state of California, are treated as a minority. This morning was an example of the lack of accessibility that has perpetuated this commission since it was established. As a former member of many of the committees that I was here, it was impossible, despite requesting accommodations which are legally required by federal and state laws. Those things never happen. We came in good faith to the invitations to the committees, and we would show up to those committees, and we didn't even have accommodations. We were not welcome. We were invited. We pay taxes. This is our lands, and yet people just take pictures or smile at us while our communities die, while our children are dying. Today is a conversation of reckoning for all those people that died during those years and all the ones that are trying to stay alive and those that will die today while there's a lack of absence of commissioners at the table. That
Hector, your
shows the
time is,
urgency.
your time. is
Thank
up.
you.
Thank you, Hector.
Joey Espinoza.
Hello, good morning, buenos dias. My name is Joey Espinoza, pronounced they, them. I'm a lifelong resident of Calexico, California, so I am here today representing the Imperial County. I work at the IV LGBT Research Center in El Centro, California, and the county behavioral health services works in partnership with us to provide services to our LGBTQ community, as well as domestic violence perpetrators. We offer domestic violence and anger management classes. I studied at UC Riverside and graduated with a double BA in psychology and education with an emphasis in community leadership, policy, and social justice. So I'm here today to ask for accountability and for your support. The behavioral health services in the Imperial Valley needs funding to be able to better address the inequities in our LGBTQIA2S+ community. They need funding to be able to train all staff, from therapists to receptionists and even the pharmacists, because it is inhumane to have to make people go through the disrespect and the trauma of being misgendered and being erased and mistreated when they are seeking mental health services and already in a vulnerable state. I am aware that this commission already funds the behavioral health services, so I am also requesting that the allocation and execution of those funds are closely overseen and the board is held accountable. Furthermore, the Imperial Valley, like the whole nation, has a substance misuse epidemic, and the rehabilitation services are very scarce. Our houseless population has the greatest difficulty accessing these services for their mental health, for housing, for employment, etc. Like mentioned before, I am from Calexico. It's a small town with a 5-minute proximity to the border with Mexico. The great majority of the unsheltered population there are dealing with immigration status issues on top of dealing with survival overall. The heat there is insufferable. We hit the 110s, 120s during the spring all the way to summer, and even during the fall. We have about 4 weeks of winter. But I bring that up because the city shelters within Calexico are very scarce, very limited in capacity. And the city with the most shelters is 20 minutes away. And the transportation there is very problematic and inaccessible to a lot of people. So I'm bringing this all up because, as we all know, this is my self-timer, sorry. As we all know, basic needs are inarguably tied in with mental health. So I'm asking again for funding and for more rehabilitation centers and shelters for the unhoused population in the Imperial Valley. Thank you.
Thank you, Joey.
Okay, that was our last in-room comment. Now for online, Richard, your line is open. You may go ahead.
Hello, this is Richard Gallo from Santa Cruz, California. I'm a person with lived experience and a former peer counselor in high school during my senior year. I wanted to ask the commissioners and the leadership staff at the Oversight Commission to review regarding peer services. Since peer trainings is happening right now throughout the state and getting ready for the certification and the Medi-Cal billing, we need to increase our peer services throughout the state of California, including peer respite programs. It's needed, it's critical. This would benefit for those who are unhoused that may come in to ask for help to get out of homelessness. This is part of the problem where we at, that our lack of programs and services have failed, where we're in a crisis mode right now with homelessness and lack of affordable housing. I want the commissioners and the leadership staff to go back and look at the voters to vote this bill that's funding the Mental Health Services Act. Peer services is part of the services. We have centers for independent living that serve the disability community throughout the state. One of the core services is peer support. And the last comment I have is I looked into the peer specialist fellowship position. I sent an email to the human resources staff person assigned with the Oversight Commission and yet have not received a response back. This is unprofessional. This is malice, especially to a person with disability, with one simple question. Since this is a fellowship position, I don't know if the benefits are included. Since this is a part-time benefit, I don't know if the benefits are going to be prorated based on the hours you're working. A simple question for a response that I cannot get back. Totally unacceptable. How am I supposed to make an informed decision whether I can apply or not, whether it would help me or affect me, depending what the benefits package is? Thank you.
Thank you, Richard.
Next, we have Jamie. Your line is open. You may go ahead.
Hi, can you hear me?
Yes, we can hear you.
Thank you. This is Jamie Ann Farrow. I'm calling from North Bay in Marine. I'm a volunteer peer, BIPOC peer, and community advocate. I come before you, commissioners, to address, not to address, to bring in awareness to what is needed here. I know there are a lot of programs and a lot of things to help peers and support peers, but can I also ask the commissioners to consider when you having peers in the roles to include peers of color, BIPOC peers. Reason being, there's no one size fits all. We are also different and unique on our own representation and intersectionality. I'm just naming one, which is I am from the AAPI committee, for example. There's a lot of marginalization, and there's a lot of things like there's no name when we ask for the word peer and mental health support. So I'm trying to bring awareness again to share that, we need to find a way to better serve our community. Being an advocate, I see a lot of linguistic barriers that are faced, culture stigma, because simply speaking up is stigmatizing in my culture. How do we bring that piece to incorporate into having peers role fulfilled? We can't just think that, okay, peers are okay having one for all. I know there are promotoras, I know there are other programs, but I'm asking specifically for the AAPI. And it doesn't denote only from Asia, but people from Samoa and Hawaii, etc. I don't need to preach the choir, but I'm trying to say that we have a lot of things that are siloed away. I tried reaching out to the commissioner, Tom Orrock. He entertained me, answered me, yes, very much first time. And I tried to connect with him again. He ignored my calls. I know that it's hard to make everyone to understand you when you don't have an organization that you're representing, or I don't have abbreviations behind my name. I'm an adult with disability. I struggle on my own through my complex childhood trauma. I bring a lot of hats along where I'm actually representing. But my chief objective of coming here today is to bring that voice for those who have been silenced, so that they do have a representation. I have connected with,
You
sorry.
can wrap up the comments. Your time is up. If you could wrap your comments up. Thank you.
Okay, I'm going to just brief. Commissioners and Madam Chair, I just want to bring to your attention that there's a grave need for peer roles in the making, especially BIPOC peers. I sincerely implore you to consider more roles that would be able to, for everyone, every different representation and intersectionality. Thank you. Are you back?
Thank you, Jamie.
That was our last public comment.
Thank you, Mariani. I want to thank everybody for your comments, and we very much appreciate them, and we do learn from those. So we will make sure that for those in staff taking note, we will make sure that we will address those that we can address immediately. So with that, I want to go ahead and move on to item number 4. At this point, we cannot take action, but I do want to encourage at this time that if there's any questions or comments from our commissioners regarding the minutes from September 22nd, I would ask that you bring those up at this time. So we're not able to approve those minutes, but if there's any questions or comments to the minutes for our last meeting on September 22nd. Seeing none at this time, I would ask if there's any public comment on agenda number 4. If so, could you please raise your hand? And once the public comment period for this agenda item starts, we will close the public comment queue. So please make your request to comment now. Also, please limit your comments to 3 minutes or less. So Mariani, will you please open the line for public comment on agenda item number 4?
Yes, we have one public comment in room. Hector, you may go ahead.
Thank you.
Buenos días, Héctor Ramírez. Soy un consumidor del Departamento de Salud Mental en el Condado de Los Ángeles. I'm a consumer of LA County DMH. It is concerning, given the fact that the state of California is in the middle of a mental health epidemic, particularly for our youth. We're in the middle of one of the largest unhoused homeless epidemics in the world. California is poised, as Governor Newsom told us yesterday, or this week, California is poised to be the richest, one of the 4th richest economies in the world. And yet, the important work that needs to be done to help our communities, the great work that is done cannot happen because people are not here. I think that really has to be a call of action internally, but then externally. The people are here. Many of us have traveled all throughout the state of California to be able to engage this commission here, particularly
Hector,
items on
this
the agenda.
this agenda item is
Yeah.
on the minutes.
Yeah,
and so
that's
your
what I'm-
comments
I'm-
need to be, please.
Thank you. I appreciate the censorship. And so the items of the agenda, not being able to address is very, very difficult, that it doesn't taken care of. And even sometimes the retaliation that we get even from trying to address it, not having the words, the expertise, or the privilege, it really highlights the power dynamics that our community suffers when items like the agenda or even basic work issues like accessibility are not included. The material is not available in Spanish, so it's really, really problematic. Again, it really highlights perhaps the problems internally with your staff that really need to be addressed so the commissioners have the support to attend and to participate and really do the business that needs to be done in front and not behind the doors. Thank you.
That was our last public comment.
Okay, thank you, Mariani. So at this time, we are not going to address the election of the chair and vice chair. We are going to move on to agenda item number 6. And let me offer this as well. With that last comment, we are going to stick to, following the public comment to the agenda items. And I want to say this, please, if I may. Every commissioner here dedicates their time, not just in these commission meetings, but in between commission meetings with the subcommittees and the other committees and reaching out to members of the public. So I would ask, there are things that happen beyond our control. We have, we work in other positions, we have jobs, we have families, we also experience crisis, medical issues. So I want to give grace to commissioners. We don't know why we can't attend some of these meetings. It is not often. I want to say this is one of the first times, probably in a couple of years, that we have not had a quorum. So I just want to offer that up. So I would appreciate that we give that grace to our fellow commissioners that weren't able to be here today and establish a quorum. So with that, I'm going to go ahead and move forward. And we are not going to go with our election. So we are going to move on to item number 6, the semi-statewide enterprise health record. So our EHR, we are going to have a presentation, and the innovation component of the mental health services provides an opportunity to explore new ways to organize and deliver mental health services. To support those goals, the Commission encourages innovation investments through multi-county collaboratives to address shared challenges and build the evidence base to support systemic improvements in care. Some examples of these are in full-service partnerships, psychiatric advanced directives, the Early Psychosis Learning Healthcare Network, Crisis Now, and Alcove Youth Drop-In Centers. Today's innovation project follows the collaborative model, and it's being initiated by CalMESA, the California Mental Health Services Authority, which is an organization that helps fund, develop, and implement mental health services and educational programs at the state, regional, and local levels. For agenda item 6, the commission will consider approval of innovation funding for the following counties. So at this time, again, we're not going to take a vote on this. It's going to be a presentation. So I wanted to share with you that this project has been shared twice already. The initial draft on September 27th, 2022, and the final draft on October 12th, 2022, with the commission's list of community partner contracts and CLCC and the CFLC. 3 comments in support were received and highlighted in the staff analysis. And there was 1 letter of opposition that was received and is provided in commission materials for this agenda item. The letter was provided to CalMESA and highlighted privacy as a concern. Commission staff raised this issue with CalMESA, who is addressing it by following current health industry standards for privacy, security, and interoperability, and are developing master consenting documents so that the consenting clients are able to give their consent for coordinated care. Page 1 of the original plan, so please see there. We will be hearing a presentation from Dr. Amy Miller, who is the Executive Director of CalMESA. So at this time, I want to invite Dr. Miller to please start your presentation.
All right. Thank you to the Commission for having me. I'm going to go ahead and share my screen to launch our PowerPoint. Okay, just wait 1 second. Are you okay seeing my screen right now?
We are.
Okay, thank you. All right. Thank you guys for allowing us to present on behalf of counties today. My name, like you said, is Dr. Amy Miller. I am the Executive Director of CalMESA. The first question that most people ask is, who is CalMESA? I'm like, what are you guys? So we are what's called a Joint Powers Authority. So we are a governmental entity. We were formed in 2009, and our objective is to support the public behavioral health system. So when we have new staff that we're onboarding, I sometimes say we're like an FSP, a full service partnership for county behavioral health. I took over at CalMESA about 2.5 years ago. And what I did kind of a landscape analysis. So I met with directors, I met with county staff, I met with peers actually too, and talked about sort of the pain points and where we could bring solutions to counties where they were struggling. You know, at that point, we were still in the middle of the pandemic. And one of the projects that really went front and center for everybody was the challenges that they are having around technology. So 58 counties having sophisticated technology staff and retaining them to manage their full scope as a behavioral health plan has been tremendously challenging. So we as CalMESA launched this project actually a few years ago, and this really stands on many previous innovations that we've done in the past. So I've done some projects with the OAC in the past around innovation, and we're really leveraging lessons learned, both for me personally, like Toby will remember the days when we met with IDEO and did some human-centered design work several years ago in the before pandemic time. We're leveraging so much of what we've learned from the past to make this project successful. Introducing myself, so Amy Miller, I'm a clinician. I started serving in public behavioral health, I think when I was about 22 years old in Monterey County. I worked myself up from an intern to eventually the behavioral health director, and then I moved over to CalMESA. So sort of the service in public mental health, I feel like is kind of at this point, after this many years under my belt, feels a bit built into my DNA. And so this is very much a passion project for our team at CalMESA. I apologize, I'm a little sick today. So what is the semi-statewide electronic health record? We have joined together with 23 counties to implement a semi-statewide electronic health record. This is the first cohort of counties. So it's an electronic health record with one vendor. We are bringing this forward as an innovation project because we are really turning the EHR upside down and what we're trying to achieve here. Getting this many counties to work together has actually never been done before at this scale with this complex of a project. Our overall aims with the project is that we know, and we already have, developed tools to improve client care and workflows. We're working to optimize outcomes and reconceptualize how we collect outcomes in public behavioral health. So less about adding on more tools and more clicks. And we are working with interoperability central to what we're doing. So interoperability is kind of a long word that maybe the commission doesn't hear a lot about. When we look at the negative outcomes of the people that we have the privilege of serving, we look at years of life lost, and those are often due to untreated physical health care conditions. So I replicated the statistic when I was in Monterey County, around 23 years of life lost for the people that we served. And they were dying due to lack of access with healthcare. We're building an EHR that's ready to exchange data with our other trading partners like primary care, and using that as an advocacy tool to improve health outcomes for our clients. The traditional behavioral health record involves thousands of pages for each client. It's frankly TMI, too much information. We're trying to get it down to a lean set of data that's interoperable and ready to trade with others. So you might be asking yourself a question of like, how is this different from other things? On the left, so being a therapist, I always talk about Maslow's hierarchy of needs. This is what we think about a lot. So people meeting their base needs. Every EHR handles for privacy and security. Otherwise, they would be shut down. That's just congruent with federal standards. But traditionally, with our pyramid on the left, we're really focused in county behavioral health on privacy and security, claiming, so billing for services, state reporting. And then we dedicate like a little bit of time to clinical workflow. But honestly, we've never had enough staff to really optimize it. I would argue I've become like an IT nerd. I led a medium-sized county, and I didn't achieve all that I wanted to just due to lack of staffing resources, because there's so much of a burden in just running that core EHR system. What we're doing over here, and I say, the innovation occurs here on the left in the blue part of the pyramid, is that we are really deeply innovating on clinical workflows. So we're still, of course, meeting all the standards around privacy and security and claiming and state reporting, but it's not the most exciting thing that we're doing. We're allocating a lot of resources towards interoperability. So building out an interface with our trading partners like the jail, child welfare. We're working on optimizing outcomes from a different perspective, both through interoperability and then collecting data more natively. And then we are completely turning around clinical workflows. And I think the most important question is the why. So the commission might be aware that during the pandemic, Medi-Cal enrollment has increased by 15%. That's actually kind of a lot for us as county behavioral health. Our workforce is down. So CalMesa just administered a cost survey on behalf of the counties in collaboration with the state for payment reform. That cost survey 9 months ago showed that 1 in 5 clinicians statewide was sort of missing. So there's a vacancy rate of 20% for clinical services. Newer data is showing that we're probably going to average with counties about 36% in clinical vacancy. So we see that demand is up, workforce is down, innovation is essential. So we say at kind of CalMesa, we have to innovate like our house is on fire, because it is, right? The status quo of adding more forms and adding more clicks comes at the cost of serving people who desperately need our care more than ever before. So we've started this project with the stakeholders, the clinicians. And in our interviews, we're hearing over and over from the providers, the psychiatrists, that, if you're able to do this for me in the EHR, I'll have more time with my clients, and that's what I'm here for. The providers are really articulating that they need to better understand, longitudinal understanding of their client's story. So the EHR isn't really just about claiming for services. It's about holding the client's story, understanding what's important, and putting that in front of practitioners in a way that's consumable and helps them to make the best choices. The practitioners are also saying, they need freedom to use their clinical judgment. We all built up sort of these monster EHRs with 1 million checkboxes to increase safety. And it's taken practitioners away from the heart of why they do this work, and has actually not really facilitated the best judgment. And then we're also learning a lot through our innovation layer about how people need to build into a foundation of the EHR, how to collaborate as a team. So our partners so far, this actually started with a grant from the California Healthcare Foundation. So we said, I think we might need to do a semi-statewide EHR. They funded the initial round of innovation to spec this out. Subsequent to that, we brought on RAND as our evaluation partner, and they actually helped us with design and vendor selection. They're helping us with outcomes research right now. We did an early contract with NCQA. So they do all of the statewide HEDIS measures, national HEDIS measures, and sort of came before them and said, if you were us, tabula rasa, blank slate, how would you design behavioral health outcomes in a way that makes the most sense for clients and care? We've partnered with Streamline Healthcare Solutions. Streamline is our EHR vendor. They're newer to the California market. And then we've entered into a contract with IDEO, a group familiar to the OAC, who's helping us with human-centered design. So they're actually out in the field this week, meeting with psychiatrists, standing over their shoulder, collecting information, seeing what real practice looks like, and then putting forward mock-ups of how the future state could better serve them. So I would say beyond the CalMesa staff, we've assembled a group of partners that puts us in a position for phenomenal outcomes. Our evaluation, our overall moonshot goal that we are planning to measure and are measuring is that we intend to reduce the clinical documentation burden. So clicks, amount of time spent documenting by 30%. So that is sort of a wildly ambitious goal, but that's what we're trying for. Because if you reduce the documentation burden by 30%, that exponentially increases the number of people you can serve, which is what everybody wants. I'm a therapist, I love technology, but I don't want to spend my time on an EHR. I want to be face-to-face with the people, driving impact. So we're doing assessments with counties that are part of this project about sort of their baseline use rate, their satisfaction, and then we'll be evaluating it post go live to ensure that we've met that target. And RAND is our evaluator in that space. Our budget relative to the innovation layer is being spent a lot on RAND, the evaluators, and human-centered design, as well as some CalMesa staff that are overseeing the project. So we have a few counties who've completed their community planning process and several that are in process that will be coming to the commission in the future. And now I'd like to stop for questions. I'm not as much of a PowerPoint person anymore. I'm more about answering questions and responding to feedback.
Thank you so much for that presentation. At this time, I would ask, are there any questions from my fellow commissioners?
I have a question, Chair Madrigal-Weiss.
Please, Commissioner Tamplin.
Oh, thank you. And thank you, Dr. Miller, for your presentation. Working in Alameda County Behavioral Health, I very familiar with the need for a strong electronic health record system, and happy to see the support you're giving to the counties that are joining this effort. And also in my role as Office of Peer Support Services, I'm going to ask because it's on my plate, and I'm working through our EHR system to make sure the 2 new codes for peer support services are added. And just if you can talk about that and how you envision, and if you guys talked about, there's the peer support services and family peer support services. And so throughout our state, there's a lot of family members that want to make sure that their role is uplifted and the uniqueness of their peer support services to family members are reflected in our EHR and in our trainings, but that's another issue. So if you could talk a little bit about the new codes that are being added, if it is, and where you're at with that.
Yeah, so obviously CalMesa is helping to implement the peer benefit across the state, so we're acutely familiar with the codes. So the new system that goes live 7/1/23 will have all of the new CPT codes and sort of role-based configuration. So people will only get the service codes that they need to use in front of them. So that will make it a lot easier for peers to bill in the system, because it won't be like a code list of 100 in front of you. It'll distill it down into what you really need to choose and support accurate codification and ensure that we're capturing all those great peer services. Additionally, I think the peer space is going to be one where we are really excited to innovate after we go live, in particular, using some more like voice recognition software and other things that will make it easier for peers to document. Because as we've been listening sort of on the peer side of the house with CalMesa, we've really heard that using EHRs is a significant barrier for people being willing to enter the Medi-Cal benefit. So as we're able to innovate, make this an easier process for peers, we know that that's going to facilitate additional peers being comfortable and joining the workforce. So that's exactly sort of the question I wanted to have, because that's the value proposition of this EHR, right? If we crowdsource it, work together, make it as easy and obvious as possible for counties to smoothly implement this, that puts them in a position to do the right thing and pull more peers into the workforce. So I hope that answered your question.
That did, thank you.
Hi, Chair. Sorry,
Please.
I always seem to have trouble finding my hand here. So I just, first of all, I love this. It's the least sexy work that we see here. But to me, if we don't make the system more effective and efficient, we are never going to meet all the needs that are so desperately needed by all these different populations that are so important to us. So I guess my question was, I see this as a project. How is this the beginning of the end or the end of the beginning? I mean, is this just the first step toward many more steps? Or if we took on this project in its full scope, would this take full advantage of the effectiveness and efficiency of the information flow as we manage it today?
100%, this is the beginning, right? So, and you've got it right. We kind of say our identity of CalMesa is we take on the boring back-end business solutions. So then people can be free in their community to deeply engage and produce solutions that make sense for their unique community. So we consider this a foundational offering of CalMesa that then is going to put us in a position to like compare outcomes across counties and say, hey, you know, Mono County is actually really innovating in a homeless outreach program, and we could scale that in Stanislaus County. Here's the average cost per beneficiary, and here's a template of how you could exactly do it, and here's how we'll measure it. So we consider this, you know, basically that's why it's an innovation, right? It's cleaning up the foundation so we can accelerate and innovate together from there and do so in a way that doesn't take so long. So by standardizing the data, standardizing the collection, and making a clinical workflow that just makes sense for real humans, so people will actually follow it and we can measure things properly, is going to give us just the beginning of innovating. And then because we are, you know, such a large cohort, so I think right now, you know, we're just in phase 1 of this project. There's a phase 2. This represents 37% of the Medi-Cal beneficiaries in California, right? So it's going to give us a good platform to test innovations. My team makes fun of me because I'm very obsessed with like a future EHR that you can run off your cell phone and just, you know, talk into to write a progress note. We're not quite there yet, but we will be. And what will that do for like improving workforce satisfaction, reducing documentation time, and engaging peers? Those are the innovations that are next on deck after we survive this somewhat ambitious project.
Thank you for that. And I would just say, we know from our education system, our math scores are even worse than our reading scores. And so when we say, you know, a system's going to be 30% more efficient or whatever, I'm not sure the average person understands most of that. Maybe we could translate that to how many more people we could serve in a particular kind of way as an example to underscore the importance of this work.
Yep. That can be one of the things we can quantify with this evaluation, sort of the average clinician being able to see more people per day, as well as like part of the RAND evaluation is asking how much time they're spending on documentation and including how much time they're spending after hours. It's like when I work long hours, I like to work on fun things, not boring things. I'm going to throw in, you know, 2 more hours to a 12-hour day. And so we shouldn't have people working harder, longer just to document for Medi-Cal.
Absolutely. And again, a lot of people say, well, why are we putting money when we have real needs today? But it's this kind of work that allows us to serve a lot more people. So thank you for that.
Thank you.
This is Commissioner Mitchell. Thank you for the presentation. I do have a question though regarding the absolute priority of the work that's been done. Like, what's going to be the first real big outcome? Because you mentioned 30% of time that clinicians will not have to spend in documentation. I think that's what you said. And we all know documentation is a really, really important part of Medi-Cal. But also, you know, there are so many other forms and related you know, paperwork that clinicians have to complete. And so, you know, I'm hearing a reduction in clicks, but really kind of what I want to know, what's the first priority that this system with the work that has been done, what is it going to do? Because I'm hearing systems talking to each other.
Yeah.
Just super important, because probation should be able to speak with mental health records should interact with, prevention records. So kind of like what's the first high level improvement in our system of care that this innovation is going to really hit? Where will we see our first bang for our dollars?
The first bang for the dollar is, I'm used to county systems. We go and visit counties, we get copies of all the forms they're doing. And in QI, you always ask the 5 whys. So it's like, so you'll see even frankly, the FSP paperwork and the way that it codifies, we've got homelessness codified 10 different places in the record, right? In a way that you can't data exchange with anybody. So if a person's homeless and you're interfacing for a whole person care client and you need their primary care doctor to know that and probation, right now we've got it buried in our, what I call like our bespoke behavioral health documentation. What we're teaching counties right now, leave your forms behind. In 2022, it's about coding things in what's called a problem list that's interoperable with physical health care. And so we're teaching people to say, don't ask a form, right? That's unique to your county that says, how are you homeless and how long have you been homeless? Put it in the problem list. So we're mapping out the workflow to make it as minimalistic as possible, because you're right that there's so many forms, but when you get down to the heart of it, they're often responding to an audit 10 years ago. That auditor's gone, the person that made the form is gone, and no one really knows why. And so we collaborate closely with the state to call the question on, in a workforce emergency, when your house is on fire, do you really need that form? Or should you get rid of the form and serve the people? So we can, retain our workers. We hear from counties, and unfortunately we can't quantify this yet, but 30 to 40, and in some cases, some counties are saying 50% of their staff's time is spent on documentation. It's not that important. That is not what we are here to do. There's a scarce amount of clinicians in the world. It is totally inappropriate that that is happening right now. So the first deliverable is cleaning house, saying, this is how we're going to codify the most important things. This is how we're going to codify food scarcity, and here's how we're going to solve for it. And leave the other stuff behind. You don't need it anymore. The world has changed. We need to be interoperable. We need to learn to talk to our friends so we can help advocate for the most vulnerable people in California. So I would say sort of spring cleaning the EHR is mission number 1, and making it in alignment with physical health. And then we innovate from there.
Okay, thank you for that, because it's the documentation that runs so many of our clinicians out of this business.
Oh yeah. I wish that we all had quantified like our exit interviews with staff, because we hear again from staff and from county leadership saying the people, they love the humans they serve. They have a heart for serving homeless, vulnerable people, but they can't stand our paperwork. It's like, what kind of tragedy is that? That people would leave the paperwork, but we would be willing to serve homeless people with schizophrenia? Like, we've got the right workforce. We need to do whatever it takes to keep them, and really call the question on every click, every single form, make sure it needs to be there. None of us like paperwork, right? Does anybody value your last interaction with the DMV? Submission of documents. It's not what humans are here for. So I think that's the value proposition that we have with CalMesa, is really, coordinating on behalf of counties, double checking with the state, vetting this workflow, and bringing a minimalistic product forward.
Thank you.
You're on mute.
Glad you saw my lips move. Thank you, Commissioner Mitchell. Any other questions from our commissioners? All right. Thank you so much, Dr. Miller. At this time, I will invite members of the public to make any comments on this item. So I will ask you to raise your hand, please. Raise the hand button on your computer or app by calling in, and on your phone, press *9. Once the public comment period for this agenda item starts, we will close the public comment queue. So please make your request to comment now. We will ask that you please limit your comments to 3 minutes or less. So Mariani, please open the line for public comment on agenda item number 6. And I will ask you if there are any public comments at this time.
Yes, we have 2 in the room. The first one is Hector. You may go ahead.
Danny, we don't hear anything.
Oh, sorry, he's going to start just in a second.
Oh, okay, sorry.
Thank you. Just kind of reiterating that when I'm making my public comment and people speak, I can't quite hear it and it interrupts my public comment. Hector Ramirez, I'm so glad to hear that you're a Cal Mesa, my friend. I remember you from our Wellness Traco initiative when you were in your district. And so I really appreciate the work that you're doing. And I keep hearing back and hearing the word stakeholder and realizing that I think that has been perhaps one of the biggest problems for this commission, realizing who is actually a stakeholder. Is it the parent? Is it the business trying to get contract? Is it the employees? Or is it the direct people, the authentic stakeholders like myself who try to get services and don't work for any of the agencies that usually you listed? And so I was wondering if within your report, you can really single out specifically the number of authentic stakeholders. And that means individuals like myself who have a severe persistent mental illness, like schizophrenia, schizoaffective disorder, how they were included in that particular work, given particularly the concerns around the state with care court and how we don't necessarily seek out services or that we don't engage. I just want to know within your process how you engage those authentic stakeholders, not particularly those people getting money. Thank you.
Thank you, Hector.
Next, we have Danny.
Good morning, and thank you for your time. My name is Danny Cesenia. My pronouns are he and they, and I am the director of the California LGBTQ Health and Human Services Network here in Sacramento. With me today, I have our Out for Mental Health project partners from across the state of California. And as I was listening to this wonderful presentation on, this new potential electronic health record, I couldn't help but think of the various reports and listening sessions that we've gathered from our communities where access to mental health care is pretty non-existent due to even electronic health records. Many times our community members are misgendered and misnamed as they even fill out their paperwork and say, my authentic name is, this is who I am. But because electronic health records have no room to actually have something for legal name versus authentic name, and this is how you need to call the patient back for any type of appointments or anything. When a patient is misgendered or called by their name that they no longer go by, it now causes our community to not want to seek out mental health services. And this is where our disparities not only increase, but this is where we also see increases of suicidality, depression. We start to see increases in tobacco use, substance abuse, alcoholism, etc. And really, access to mental health really starts at that very first step of who am I and how am I being called back to when I'm trying to see a provider. The other major issue that we have is the lack of data in our communities. And by this new electronic health record, this is the perfect opportunity to ensure that you are capturing SOGI data, sexual orientation, gender identity data. This is something that we have been struggling with, not just in mental health services, but even in access to generalized healthcare as well. This is data that even DMHC, DHCS, HCI is not able to provide because no one is collecting it. So as we are creating new electronic forms, as we're creating new ways to access mental health care and making the job of our providers easier, I really want to advocate and ensure that our community is kept in mind as these systems are being built. Thank you very much.
Thank you, Danny. Dr. Miller, that's something that has continuously come up, and I do want to ask regarding legal name versus authentic name and sexual orientation data. Is that something that is being captured?
So this is an example of us using, the best professionals we can find. So we asked RAND to do a full federal landscape analysis to look at the best way to codify all of these things to be in alignment with interoperability standards, because it's not going to be good enough if I make it my EHR, but it doesn't let the primary care provider know that that's that person's preferred name. So we have built that into our EHR and started first with the landscape analysis, sort of future oriented, and are doing the best we can to make sure we accommodate for all of the different preferences. So feeling strong on that.
And capturing the sexual orientation data then is also, okay, thank you so much. Amariani, please.
That was the last one for in the room. Now online, we have Steve. Your line is open. You may go ahead.
Thank you. Good morning, everyone. My name's Steve McNally. I'm in Orange County, California. I'm a family member of the son with schizophrenia, and we're lucky enough to have all relationships restored. I'm also on a county-appointed behavioral health board, but my comments will be my own. I guess my question is, possibly you can all post the details to this project if there's more than just this presentation, because what I'm seeing is 5 counties that did community planning, but no idea of how many people attended, how many were county staff, how many were providers associated with the project, how many were families, and how many were system users. That's one. The problem presented certainly is one we're all familiar with. And I'm just wondering why Medi-Cal isn't here, who would be interested in making sure that or maybe they are part of the project, but making sure that they simplify everything to all the federal, state, and any codes that are required. The other thing is that our experience with the system isn't so much the coding, is that the psychiatrists really don't want to treat families, even though everybody wants families to be treated, and they hide behind the HIPAA law, which the U.S. Health and Human Services has said doesn't necessarily have to be an issue. The guy who was in charge of HIPAA made a presentation to the NOLA group in New Orleans. And then lastly, I don't see the other 23 counties. So I guess what I'm trying to think of is, how is this going to be interoperable to the existing? And do the counties that have done the community planning, do they have electronic health records? And then I guess one last thing is, I'm a little nervous having Cal Mesa in charge of a project as a captive arm of the behavioral health directors, when they're so they're not very transparent. They don't have e-lists. They're not easy to track. And the Tech Suite project, the peer certification projects have been very difficult and almost impossible. They didn't start on, the peer certification didn't start on July 1. It's still very confusing to people in the state. They wouldn't focus on implementation, and they handpicked people. These are my comments. I guess I shouldn't say they handpicked people, but providers who got contracts were on the special counsel. So I just think you need an awful lot more scrutiny than you give, and trust from the state to the counties, counties to the communities is very broken in this state. So until we repair that,
you can wrap up your comments.
I will
Thank
wrap
you.
up. Thank you, Tom. I think we really need to come clean and honest with what's going on, acknowledge, don't dwell, and move forward, going to the same common future. Thank you.
Thank you, Steve. And the full description of the project is listed both on our website and on the Cal Mesa website. So you can get all those details as to who participated and who was present. So appreciate that, Steve. Thank you. Mariani, who do we have?
Yes, next we have Anna. Your line is open. You may go ahead.
Thank you, commissioners, for this opportunity, and thank you, Amy, for this presentation. I want to commend you on attempting to reduce the paperwork. It's always a welcome endeavor. What I would like to point out is, or rather ask a question. as we're trying to minimize, which is great, the time that we spend documenting and the time that we spend with the clients, are we looking at the fact that this question, is our documentation supporting or hindering our clients' recovery process? Is it empowering? And I can answer that question today because I've spent over 16 years working for Contra Costa County Behavioral Health as a peer support specialist, and my answer is no. And I'm sure as a provider, you're aware of that too. So I believe this is I hope you will take this as an opportunity to look at the language as well. And to do that, please, please involve peer support specialists, advocates during the development process, not, excuse me, not as an afterthought. This will allow to humanize the language. It will make it easier for everyone. And the last thing is access, to make sure that the system is user-friendly for those of us who receive services as well. Thank you.
Thank you, Anna.
Next, we have Jamie. Your line is open. You may go ahead.
Hi, good morning. Dr. Miller, I come before you as a peer from my county. I was one of the peer leads that actually did the Intact Street project. And I wanted to bring to your awareness that when I first be on the project, it was so much hardship being a peer because Mandarin is actually at its infancy. So there were not many peers, but I'm a volunteer, so I signed up for. And there's a major disconnection between the peer lead and the tech lead. So I just want to understand, because it sounds like you wanted a project to be driven by peers, like to be able to help it grow. If that's the case, why is the information so, like non-shareable between the two leads? I want to help my committee to represent them and address their disparities when trying to access to, using the app and etc. in the initial stage. But I was not allowed certain information to like a preview. I can't do anything. I felt there's a very much like no connection, because it seems like you say you value peers. Where does the value come from? I know you have your peer collaboration meeting every month. I remember trying to go down to a meeting together with the group, but because I was a volunteer, I was stigmatized. I asked the problem, I said, I want to go. I don't have no means. I'm a community member. They say, oh, you ask your county. When I asked my county say, ask CalMesa. So where's the means and the support for the stakeholders? There's no one size fits all. I'm a BIPOC person, and I struggle a lot to bring normalization to those who don't speak the language, the culture barriers, and also the culture stigma, and linguistic barriers. I speak 6 languages, but the thing is, like, I'm still not adequate enough to connect because there's no information for me to correlate. And I'm bringing this up very quickly because my time is limited. So just hold on for me for a minute. So what I'm trying to say is, like, when we have programs like this, I vetted all the apps, and yet in some way there's a lot of hardship for people for the demographic, the cohort number 2, which Marine is on, because our demographic is on older adults, the same like San Mateo County. So how do we connect more in a way that is like when people don't speak that language? And for people with disabilities, not only mentally, but physically, like myself. And I'm not older adult, and there's actually a need for that. We want to also think about those.
You can finish your comment. Thank you.
Okay. So I'm trying to say there's a lot of broken pathways to help peers. And sustaining and creating further would be something we like to be able to see. So maybe I can connect with you later on. Thank you. Thank you, commissioners.
Next, we have call-in user 2. Your line is open. You may go ahead.
Hi, this is Mark Carmatz, and I have a question for Cal Mesa, and that is why are they using the Rand Corporation due to the fact that they were the ones that did the research for the Vietnam War that took place in the 1970s. It's and late 1960s. The reason why I'm asking is because they did research for that war to take place, and so at that point there was a lot of trauma that took place in Vietnam due to the research that they did. So I'd like to know why we are still funding, why there's coordination with them. Thank you.
Thank you, Mark.
That was our final public comment.
Okay, thank you,
I'd like an
Amariani.
answer.
So,
Do you want me to respond?
yes, I'm sorry, Dr. Miller. Yes, I think the question was
I would just
Rand.
say, yeah, there's many different factions of RAND. Certainly, they've evolved a bit over the last few years, but there's a branch of RAND that we work carefully and closely with that deeply understands behavioral health. They're actually researching a lot around psych beds and other behavioral health needs. And so we've appreciated the specialty that they have in public behavioral health. They know us, they know our language, they know the data behind the problems we're trying to solve. And so we're leveraging a long relationship with RAND to expedite this project.
Thank you for that response. At this time, I don't see any other hands raised on Mariani. Is that correct?
Yes, that's correct. There's no more public comments.
Okay. Are there any other questions from commissioners? I see none. Okay. Thanks, Mariani. So, Dr. Miller, I appreciate your time here with us, sharing your report. Thank you very much. And we are going to go ahead and move forward at this time. So thank you for your time with us here today. And thank everybody for their comments and their questions. And we are going to move forward on our agenda. Thank you, Amy. Appreciate your time. So the next item is agenda item number 8. The commission will hear a presentation from staff on the racial equity plan. As you recall, about 2 years ago, the Commission joined 37 other state agencies in the Capital Collaborative on Race and Equity. 16 Commission staff participated in trainings and learning from a consultant to enhance our internal operations to support racial equity. In August of 2021 and in March of this year, we heard presentations from the Commission's consulting psychologist, Anna Nafee, and the Commission's Chief Administrative Services, Lauren Quintero, about progress and areas of opportunity related to developing a racial equity plan. Since then, staff have met with the Commission's Cultural and Linguistic Competence Committee, commissioners, and other community partners to continue to gather feedback and enhance the plan. Today, they are back to review the racial equity plan and we'll be sharing what those updates are. So with this plan, the Commission has the opportunity to leverage strategies identified in the strategic plan and begin to address structural racism in California's mental health system. So at this time, I want to welcome back Anna and Lauren. If you can please go ahead.
Hi, my name is Anna Nafee, and I'm the consulting psychologist for the Commission. Can you hear me?
We can.
Closer? Okay. My pronouns are she and hers. And Lauren?
And I am Lauren Quintero. I am the Chief of Administrative Services at the Mental Health Services Oversight and Accountability Commission, and my pronouns are she, her.
So thank you for having us back. We're here, we were here last in March of this year to talk about the Commission's racial equity plan. And we're back again to review the plan and discuss a little bit about the changes that were made. Just a little bit high-level overview of some of the changes that were made to the plan. We've talked a little bit more about tribal engagement, and that's an area that we want to get into a little bit more. We've talked a little bit about changes in grant making and a little bit about the role of the Cultural Linguistic Competence Committee in accountability and overseeing the monitoring the plan. So as you know, the MHSA certainly highlights the role of race and health equity in the Act. The Commission's mission statement also highlights the need to transform the mental health system. In order to make that transformational change in mental health, we want to centralize race and health equity in our work. And believe that that is a central facet in being able to address the needs in the mental health system.
Okay, so this ends up being quite timely. We started going over this when we started with the core team, and we were driven by the fact that racial disparities are highlighted in the MHSA, and we are aware that directly confronting racism is the way to open up pathways for everyone. Since we did the first read in March at the Commission, Governor Newsom actually issued an executive order in September, so fairly recently, that had to do with racial equity. And so under that order, state agencies and departments have to embed policies and practices in their strategic plans and incorporate more inclusive public engagement and data analysis to better serve all Californians. He also established the Racial Equity Commission, which was developed with Senator Richard Pan. And the exciting thing about that Racial Equity Commission is that they're going to be making tools and providing assistance to state agencies to make sure that they're embedding that into everything. So we had started our process before that executive order, and it almost is like a wind in our sails, carrying us forward toward our goal that we have in the plan, our goals in the plan. So the Capital Collaborative on Race and Equity, we had a lot of staff participation here at the Commission. Anna and myself as the co-leads, as well as Andrea Anderson, Marcus, Latanya, Vicky, Kayla, Amanda, Kai, Tom, Norma, Grace, Lester, Cody, Sharmel, and Reem. We're all a part of it. Kayla and Amanda have left us since then, but their impact on it was still very much appreciated and helping us, along with the other cohorts, develop this plan. So we didn't just do it internally. We did, before we even started with the Capital Collaborative, Toby sort of queued up everything at the Commission in June of 2020. And then throughout that process of us being part of the collaborative, which was August 2020 to October 2021, we met with the CLCC in May of 2021, November of 2021, February of this year, and May of this year, so that we could bring them along as we were part of it, but then also to get that firsthand communication back and forth, which Anna sort of highlighted that we've made changes since the first read on the plan. So the CLCC especially has been just so valuable in helping us make it more of a thorough plan.
So in terms of the plan, this is the Commission's first racial equity plan, and so we know and we acknowledged early on that in order to make an impact on racial equity to start, we had to look at ourselves and look at our own operations how we can better address disparities and racial equity in our own work. Again, with this being the first version, we intend to continue to iterate on this plan as time goes on. So we looked at these central functions of the commission and thought through how can we centralize race in each of these functions. So in the commission meeting planning, how can we identify diverse speakers to come speak with the commission? How can we identify a variety of different locations that are in communities, diverse communities? One of the main things that we're focusing on is the diversity, equity, and inclusion of our own commission staff, and thinking more broadly about our recruitment efforts, with the understanding that as we bring in more diverse staff that match our communities, that will help bring increased expertise in our work. We looked at grant funding, how we can deploy best practices in our grant funding, both in our outreach, but also in how we give out grants. In terms of innovation, we looked at the large collaborative that focuses on health equity, and the commission sponsoring that work, as well as working on an optional template that the counties can that will help the counties explore how to look at race in their own planning process. In terms of research and evaluation and policy work, similarly, it's about engaging diverse communities, engaging subject matter experts in those diverse communities, and ensuring that our work represents the needs and includes solutions that for diverse communities. And then in communications, we looked at how we might include more diverse representation, as well as reach diverse communities in our communications. And finally, one of the things that that we thought might be really important for the commission is this racial equity declaration. This is something that that really puts a stake in the ground, and the commission can use in its communications to clearly identify the role of structural racism in the mental health system, and an intention to address it in all of its work. And we won't do that, so thank you. Happy to take questions.
Thank you. Commissioners, any questions regarding this presentation and the work that has been done? I see none at this time. I have a question. Anna, when you talked about how we're going to reach this out in our communications, can you give me a specific example?
Yeah, just a moment. And looks like Toby might have an example as well. We talked about, so one of the examples is that we've had a contract historically with Crossroads Media, which is a company that reaches Asian Pacific Islander populations. And that's a way that we can reach communities that in diverse languages that the commission might not normally have a reach to. So one of the ways that we talked about is contracting and using those diverse media outlets to reach diverse communities. But Toby, if you wanted to add to that too.
Sure. Thank you for the opportunity. The intent here is to be really explicit and intentional in the work that the commission is doing, throughout all of the various functions. Communications is, as Anna and Lauren have pointed out, gives us multiple paths. Comments earlier about access to our materials in diverse languages, our ability to develop our website in ways that it is translated to better reflect the needs of various language communities. So ways in which the communications that we do are more responsive to the diverse population, but also the kinds of narratives that we're developing, the storytelling, the representation around stigma, around public engagement, also can be very intentional in terms of more reflective of the diversity of California's populations. So lots and lots of many ways. So for example, the commission actively supported and participated in the Hiding in Plain Sight documentary. It's available in Spanish. We've been working with school organizations to disseminate the screenings of the film and putting panels together. And so many ways, many pathways for the commission to embrace diversity, equity, and inclusion through our communication efforts. And the whole point of this is to be explicit, to learn, and to get better over time. I hope that helps.
It does. I think as I'm thinking about, all the work that we had to get out to those to groups that we don't normally have interactions with, when we were our community engagement, I'm thinking specifically around PEI, and when we brought different groups together, I'm thinking communication and reach out that way. I think that's what I was thinking of, Toby. So being really intentional of getting out, so we have members of the public who come to our meetings, but how are we really providing reach to those groups that aren't necessarily represented in our meetings here? So I appreciate that. So thank you for that response. Are there any other questions or comments from commissioners at this time? Okay, seeing none at this time, I would ask that we have members of the public may request to make comment on this agenda item. So raise your hand button on your computer or app, or if calling in by phone, push *9. Once the public comment period for this agenda item starts, we will close the public comment queue. So please make your request comment now. Please limit your comments to 3 minutes or less. Mariani, please open the line for public comment. And at this time, are there any public comments? Raise your hand now as the queue will be closing. And at this time, I see a couple. So, Mariani, they're open. I see Stacy. Please.
We have one in the
I'm sorry.
room.
We have people in the room. Sorry, I can't see the room. So we'll start with the room, please.
Yeah. Hector, may go ahead.
Thank you, Hector Ramirez, Los Angeles County DMH consumer. I remember when you started this work, why it was so important. Having been participating in this council, I realized that equity was a significant barrier even within the commission. And actually the reason that Governor Newsom signed that bill was because of an example of the lack of equity in this particular room and some of our other agencies that we were having. DEI is last decade, just so you know, is missing accessibility in there. Things like trauma informed, like what happened this morning, it really activates us. This is a mental health, having a hostile environment, having power differentials from the people that sit at the table and the way they respond to us. When we ask for basic things that are required by federal law that have been established for 30 years, those are cultural things. And we see that people with disabilities, particularly people of color like myself, experience significant access, not only for services, but even trying to advocate. I leave this meeting, again, just feeling the mental health trauma as a person of color, having somebody who is not a person of color, again, directing how I should talk, what I should say, and then the silence in the room as it happens. In Los Angeles County, we are reckoning with the racism that exists in our county. We are addressing it and we're calling it out. Equity is a word that we have to use, when we can't talk about or we're not allowed to talk about racism. And there's racism in mental health, even in this room. And I think it's important to really call it out because I feel it. It is what drives my community, my peers with mental health conditions. People with mental illnesses don't drink and do drugs because we have a mental illness. It's because of how we're treated. People with mental health conditions don't end up in jails or homeless because we have a mental illness, but because of how we're treated in those spaces. You know, I'm wearing the United Farm Workers shirt to represent my community because when the Mental Health Services Act was passed, it was my community that activated. And we're not here in Sacramento, so we didn't get the kudos. We didn't get a seat at the table. Peer certification happened, not because of what peer organizations in San Francisco were doing, but because the United Farm Workers, we realized it was an important thing and we were not even included. So realizing that the work that you're doing still has to be advanced and is very, very important, and it really should be priority, because at the end of the day, the work that happens in this commission and the lack of really acknowledging the racism in this room is what has been oppressing people of color like myself. And that's the majority of us who are struggling to survive. That's the majority of us who are in prisons. That's the majority of us who are homeless out in the streets. And that's the majority of us who are dying. Thank you.
Thank you, Hector.
Next we have Stacy. You may go ahead.
Good afternoon, Commissioners. Stacy Hiramoto with REMCO, the Racial and Ethnic Mental Health Disparities Coalition. My pronouns are she, her, hers. First, I would like to acknowledge and thank Hector Ramirez for his comments. I know it's difficult to make comments like these, but I thank you, Hector, for your courage. First, the Commission is to be commended for embarking on a racial equity plan. And your plan does have a nice background on the MHSA and CCOR. I am glad that the Cultural and Linguistic Competence Committee was involved, but I wish that they had been able to see this final plan before it was brought to the Commission. It's a little unclear to me if this is just the foundation, because I did not see a lot of specificity nor many meaningful measurements. If the Commission will go on to develop more explicit actions and measurements, then please disregard my next comments. Although I believe this process is taking a long time because you have started it a couple of years ago. In honesty, most of the actions and the plans are things that, frankly, I think the Commission should have been doing already. I do not believe the plan really stretches the Commission the way it could, because I believe in all of you. For example, one of the items under diversity, equity, and inclusion and staffing says, partner with other state agencies, leading organizations, and others that embrace diversity, equity, and inclusion standards. Partner to do what? Also, how will you know whether that state agency or leading organization has a good DEI standard, and whether, even if they have it in writing, whether they follow these principles? And if you find out that a particular agency doesn't have a good DEI standard, does this really mean you will not partner with them? Another goal in the section says, measure and monitor progress in achieving diversity, equity, and inclusion standards for the Commission's workforce. Well, what are the current statistics on the Commission's workforce, and how many people of color, for example, and from the LGBTQ+ community are in top management? Well, and what will be the goal? Other questions I have, who is the point person for this? Well, every person that the Commission hires and is employed should be concerned and pay attention to these issues. There should also be an equity officer, so people can go to that person, and the person can be the person that will answer questions. Will there be a report to the Commission on a yearly basis? I just have some of those questions, and I'm sorry to have to be critical, because I think the Commission is trying, but I was really hoping for a little bit more. Thank you.
Thank you, Stacy.
Next we have Richard. Your line is open. You may go ahead.
Hello, Richard Gallo from Santa Cruz, California, Access Ambassador with Cal Voices. I'm skeptical of the plan. I'm hoping that the commissioners and staff, especially the leadership staff of the Oversight Commission, will follow through on this and not do lip service. That's my concern. That's why earlier I asked about the peer support services. We shouldn't have to wait until a state certification happens. Just like with Care Court's happening, we shouldn't have to wait until Care Court happening. These programs and services that serve the mentally ill population should have happened all along. I just hope that this will be with open-minded and not with bias, not turning on deaf ears, not turning on a blind eye. Take it to heart. And I hope that the commissioners would ask the leadership staff about the declaration. I strongly do not believe that the counties are going to embrace it because they play politics as usual. Nothing's about us without us. They do not want an open communication with the mental health community. They want to operate the old way before the MHSA was kicked in. They do not like the community planning process. If you want to get real with what the intent of the MHSA is within the organization, within the commissioners, and with those partners, and a lot of us are on this phone, are committed and compassionate about what's happening in our communities throughout the state. Stop being biased. Stop playing politics. Move on what needs to be moved on. And I hope that this will be moving on. Thank you.
Thank you, Richard.
That was our last public comment.
Thank you, Mariani. At this time, are there any other comments or questions from commissioners? Okay, seeing none. At this time, I want to thank you for the presentation, and Anna, and thank you for, I don't see you anymore. I'm sorry.
We're here, and I want to thank the people that did the public comment. I know that Anna and myself, we know that we have a long, long, long way to go, and we know that a lot of stuff should have been done already. So we want the criticisms, we want to keep getting better, and we know it's going to be a slog. We didn't expect to present this and just get like a, oh, nice pat on the back. Like that wasn't why we got into this at all. We care about this deeply. And so the feedback that we're getting is extremely helpful and will help drive us forward with this in the future. So I just want to thank you, those of you that made public comment, because we really need it.
Thank you, Lauren. Thank you, Anna. Thank you both for being here.
Thank you.
All right. All right, so moving on to agenda item number 9. We will hear a presentation from staff on the strengths and challenges that counties face in developing transformative innovation and explore concerns and opportunities. So the commission contracted with a nonprofit consultant, Social Finance, to better understand the challenges that counties face in developing transformative innovations and to recommend ways to help overcome these challenges. In April of 2022, the Subcommittee on Innovation supported a package of recommendations that could help counties develop transformative innovation projects, refine the Commission's review process, and increase the dissemination of learnings. The INN Action Plan, PPT, and all associated documents summarizing the recommendations are included in your meeting materials. Before we get to the presentation, I would like to invite Commissioner Danovich, Vice Chair of the Subcommittee on Innovation, to say a few words on this work. Commissioner Danovich. I'm wondering if we lost Commissioner Danovich. Sharmell, Toby, do we know if Commissioner Danovich is?
Okay, it looks like he's on, but
He might have stepped away, but he is on.
okay, that's okay. I guess he can.
He can come in maybe afterwards. So
Yeah, that's
okay.
fine.
So then I'm going to go ahead and invite Sharmell Shaw, Chief of Program Operations, to begin that presentation for us. So Sharmell, you're up, please.
All righty, thank you very much. Good after, well, still good morning. We're ahead of schedule here. Good morning, Chair and fellow commissioners. If we can put up my slides. Oh, maybe I need to do something here. Oh, whoops, there we go. Okay. I wanted to take this opportunity to share with you the work that has been done to understand the strengths and challenges of the innovation component, explore concerns and opportunities, and present a plan to help counties develop transformative innovation projects, strengthen the Commission's review process, and facilitate learning across and within counties. I hope to cover a little bit of the background, a little bit about the Social Finance Systems Analysis Project, the concerns and areas of opportunity, and then the innovation implementation plan itself. I'll go ahead and start with some background. In 2018, the Commission had identified 4 opportunities to improve implementation of the innovation component. The first one was to provide strategic guidance. This is how we encouraged promoting a collective strategy with subject matter experts to identify statewide collaborative opportunities, much like the ones the chair had mentioned in the previous agenda item, FSPs, psychiatric advance directives, and more recently, Crisis Now. Secondly, supporting technical assistance and training. We use the state's broad innovation sector to support the goals of innovation through utilizing subject matter experts. Thirdly, enhance evaluation. We encourage building evaluation strategies into the design of projects, much of what we saw in our FSP multi-county collaborative. And lastly, disseminate information. It's really important to share the lessons that we've learned. And so mechanisms like innovation databases and technical assistance calls has currently been helpful in doing so. We know how hard it has been for counties to develop innovation projects with the potential for transformational change. It's also been challenging to support the shared desire for learning and to help each other develop the capacity to try something new, evaluate it, learn from it, and significantly improve mental health services statewide. As a reminder, in 2020, the Commission launched a project with the nonprofit Social Finance to assess barriers to developing transformative innovations and ways the Commission can improve its approval process and support learning from innovation projects. This is outlined in the Innovation Action Plan that has been provided to you in your materials. The Innovation Action Plan details each of these and was a valuable foundation of opportunities to improve the development of innovation proposals at the county level, at the Commission's review and support of statewide learning. From an analysis of nearly 300 challenges resulting from over 100 interviews, Social Finance did a deep dive and produced recommendations in 8 key areas. If you look at page 10 for the description of their methodology and pages 5 to 7 in the Innovation Action Plan for more information. The recommendation matrix, which is also shown on this slide, also is included in your materials for this meeting, supported our team's effort in the selection of the actions and were prioritized more to achieve impact and not necessarily ease of implementation. Staff is recommending today a focus on a core set of these recommendations and not a full array. As a result of that work, 3 areas of opportunity rose to the top, with specific recommended actions for each taken from the 8 key areas that can support the overall goal to help counties build the capacity to innovate and support the Commission's authority to approve innovation projects. These were presented and supported by the Subcommittee on Innovation in April of 2022. I'll go through each of them here briefly. The first one is help counties develop transformative innovation projects. County and community partners report challenges with understanding the requirements of innovation proposals, what's necessary to obtain commission approval, and how best to engage communities in their development. To address those needs, Social Finance had recommended the following: that we can develop an FAQ, a document that would clarify the innovation plan requirements and the Commission's regulations. We would also develop a community engagement resource where we can empower local voices, perspectives, and alternative strategies for developing plans, such as using human-centered design. We also want to review the support tools. We think it's extremely important and valuable to periodically convene counties and community partners to assess the impact of these tools, to see if they're even working, if they're even helpful, and if we need to make refinements. And lastly, expand technical assistance. We feel that it would be important to expand the Commission's existing capacity to offer technical assistance and capacity building to support counties and community partners. This is consistent with the work that's already occurring with our Alcove grant program, early psychosis, and school mental health, with a focus on Commission identified priorities that can be transformative. The second area of opportunity is to strengthen the Commission's review process. Commissioners have expressed concern that the MHSA innovation component has not generated sufficient system-level reforms and that successful innovations are slow to scale. County leaders have also expressed frustration that it is unclear what the Commission is looking for when reviewing innovation proposals. To address those needs, Social Finance recommended the following: developing a simplified innovation project summary. This would focus on the problem to be addressed, key community concerns, community involvement in innovation proposal development, and the potential for the innovation project to be transformative and/or scalable. Looking at key lessons through evaluations and how the proposal will be implemented, including budget and evaluation. This may also include sustainability planning, which is extremely important as well. Secondly, Social Finance recommended creating a discussion guide for reviewers. This is something that the commissioners may use and also community members can use when reviewing innovation proposals. And lastly, enhanced support for commissioners. We believe it would be very beneficial to develop innovation-specific orientation materials for commissioners, including staff briefings and sample plans, so that commissioners can have a clear idea of what the innovation process is internally and what counties are doing externally when they bring these projects forward. The last area of opportunity is to facilitate learning across and within counties. Commissioners have raised concerns that lessons from innovation proposals rarely make their way across county lines, limiting the opportunity for learning and scaling and replicating by other counties. To address this issue, Social Finance suggested that we develop and disseminate case studies of standout practices and processes used to design and implement innovation proposals. Create a database of outcomes with qualitative and quantitative information about the population of focus and other important elements of the project. And lastly, design and launch an innovation summit. One, to share learnings and celebrate successful innovations, identify key priorities for transformative innovations, and expand awareness of the innovation component of the MHSA and identify new partners to support its success. So this implementation plan would fortify the Commission's support for innovation projects in ways that improve overall efficiency, effectiveness, and mental health outcomes for all. I wanted to mention that Social Finance, in partnership with counties, Commission staff, and community organizations, have prepared drafts of several of these actions. And based on direction from the subcommittee in April of 2022, Commission staff have begun preparations to implement. Thank you. Any questions?
Thank you, Charmel. I would like, I know Commissioner Danovich has been working closely and leading some of the efforts with this group. So Commissioner Danovich, I invite you to share some of your thoughts and highlights of this work.
Sure. Well, thank you, and apologies, I had to step away to take a call. Plus things were going too smoothly. I had to put some wrinkles into the meeting. Let me just say that, the goals of the innovation mechanism would seem to be really easy to do. Hey, identify some problems, develop novel solutions, implement the solutions, evaluate the effectiveness of those solutions, and then disseminate or share information about them so others can do them. Sounds straightforward, but it's not at all. It's every step of that is very, very difficult to do. And ours is a system of care that was designed to be very reliable, but not very innovative and novel. And throughout my time on the commission, the challenge and the opportunity of the challenge of taking advantage of the opportunity to support innovative plans is one that has eluded us. It's been very difficult. So I say that because we generate a lot of reports, and in this particular report is one that I would encourage you all to read because it's really readable, it's really coherent, it's really compelling, and it reflects really thoughtful and outstanding work and collaboration between our staff, Charmel and her staff, and social finance. That was just an absolutely outstanding group of consultants, Jake Siegel, Kyle Doran, and the entire team. And they took painstaking efforts to listen to the commission, to listen to staff, to listen to representatives of county, to listen to stakeholders, and to take all of that input and put together a set of recommendations that are understandable, are coherent, are feasible, and should help improve our processes. So that's the report that you have. You can make your own judgment about that, but I think it's very readable, understandable, and practical. And it's now incumbent on us to put it into use, put it into practice. And I think if we do, then it's going to really help us move forward with taking advantage and seizing some of the opportunities that we have with this really unique and important, if sometimes unwieldy, mechanism of innovation. So thanks to all that were involved. Really, really grateful for all the hard work that went into this.
Thank you, Commissioner Danovich. Commissioners, any questions regarding the report, the process?
Looks like Commissioner Brown has a question.
Commissioner Brown.
Thank you, Chair. It's not a question, it's a comment. And I just wanted to commend Commissioner Danovich and Commissioner Boyd and Charmel and all the staff that worked on this in conjunction with social finance. And I really think that the end product is an excellent example of taking, as Commissioner Danovich mentioned, a very complex issue that is difficult, but boiling it down and presenting it in such a way in this matrix that it is simple to understand. It is not so intimidating to people that they shy away from it and don't even attempt to take a look at it and incorporate it. It really is a great baseline upon which I think counties and others can use this to take a look and see how is our current system, how is our current plan, working, and what can we do to address it and to be more innovative. And I think the approach to this was in and of itself very innovative. So I commend the people that were involved in this.
Thank you, Commissioner Brown. I too just want to say, in reviewing it, this has been something that has, I think, conversations with fellow commissioners in the time that I've been on the commission, that $1 million question. What does innovation look like? What are we doing? How do we measure it? And so I appreciate the leadership of Commissioners Danovich and Boyd in bringing this group together, and the staff. Charmel, I know you've shared pieces of this with me along the way, and it has been exciting. And to put this together for commissioners, and really the pieces that are broken out to share with our counties, I think it's important. The FAQs and the community engagement resources, because they don't necessarily look alike in all the counties. And I think it is important that we highlight this, and just how important, to make sure that we have community voice, and it should be developed by the community for the community and not just a sidestep. So I appreciate all the tools that have been lifted up in this. So thank you, Charmel, the team, everybody who has done this. I hope that we can, use it quickly, implement it, and make sure that we are referencing it to all of our counties as they develop their plans. So I greatly appreciate it. I don't know if there are any other questions or comments from our fellow commissioners. I see none at this time. Mardiani, am I correct in that?
Yes, there are no other commissioners' questions or comments.
Okay, so then I would ask then if we will move on to public comment. So at this time, members of the public may request to make a public comment by clicking the raise hand button on your computer or the app, or if calling in by phone, push *9. Once the public comment period for this agenda item starts, we will close the public comment queue, so please make your request to comment now. I would ask that you please limit your comments to 3 minutes or less. Mariani, please open the line for public comment, and we can go ahead and begin.
Okay. In room, we have Hector. You may go ahead.
Just setting up my timer so I don't go. Okay. Hector Ramirez, I'm a Cal Voices Access Ambassador out of Los Angeles County with the Department of Mental Health. And I really appreciate this, I really, really do. Having been involved with this commission for over a decade, I have really followed this particular part of the MHSA and really have seen how, and this is of course no reflection to you because I know you work really hard, how this particular part has been bleeding taxpayers' money. It was supposed to really provide innovative ideas for our communities, particularly our most impacted and disenfranchised and marginalized communities. And that's a key word for people of color. And this is an area where the MHSA, because of lack of oversight on how this particular programs were being implemented, really has led to counties utilizing this as an ATM for their counties to try to fund organizations or programs that ultimately, some have benefited our community, but over largely they haven't. And because of the lack of oversight and accountability, particularly like LA County needs to be audited. I keep telling Toby in this commission, LA County needs to be audited over and over and over. We have the largest population of people with mental health conditions in the world. And yet accessing some of these programs, being able to engage, provide feedback is impossible. The level of hostility like we experienced this morning is only at a magnitude of 100 when trying to engage counties in this particular programs. I love the work that Cal Mesa has done, but having been a central focus of managing these programs, it has led and replaced authentic stakeholder communities. Again, the word stakeholder has been used to really silence the people that needed the help. We have marginalized communities like our LGBTQ community that have to get funding from HIV and tobacco money because there's limited and no funding and hostility from this commission to really focus on the work that we do. Our tribal communities, our Latino Hispanic communities have to fundraise to be able to provide basic services, but yet counties are really have failing, particularly around stakeholder involvement. The lack of accessibility, which is a legal requirement. The ADA is 30 years old. It is not something that we're going to learn and do better. No, it's something that this commission should have done better a long time ago for our communities. The availability of language in other languages is something that we have been telling over and over and over. So, it just really highlights, one of the major deficits and problems with this commission. And I really hope that you learn the difference between listening and hearing. As I know you listen to me, but you're not hearing me and you're not hearing our communities.
Thank you, Hector.
And then that was the final one for in-room comments. Online, we have Richard. Your line is open. You may go ahead.
Hello, Richard Geller from Santa Cruz, California. What I want to know is, did the contractor, social finance, interview peers regarding the innovation project? It's a yes or no question. Secondly, how many projects has the innovation been approved since the Oversight Commission started? I cannot read the paperwork from my phone. I would have to go back later and look through your documents that's in your packet. The thing that I noticed that's missing that needs to be part of the innovative plan is you need to include peers. Give them stipends for their feedback. They can tell you whether that particular project or program will work or not, whether the county is listening to us or not. That's what's missing out of this document. We're not being included. We're not part of the team to educate, to learn, to see whether this project is going to succeed or fail. Cal Voices had a meeting a few weeks ago where the state ambassadors throughout the state had a meeting that maybe it's time that we get rid of the innovation project if it's such a huge failure. We're throwing money out with no success, high success rate. Maybe it's time to replace this with peer support services and programs that should have been done a long time ago to help our communities in need throughout the state with all communities involved. That's what's missing out of this document, and that's what's not included, which is shameful. How do you expect a program to improve if you're not going to include us? I'm a person with lived experience. I help individuals out of homelessness. It wasn't an easy task in Santa Cruz because we're a smaller county, smaller resources, smaller housing availability compared to the Bay Area. But I was able to help the severely mentally ill get out of homelessness. It takes partners with community agencies to help those individuals that have help. Include us. They can tell you what works and what doesn't work instead of throwing money away under the innovation plan. Thank you.
Thank you, Richard.
Next we have,
Charmel,
so sorry. Go ahead.
I'm sorry.
Yes.
I do want that. Charmel,
Yeah.
I know there was resources specifically to included for the counties when they're talking about community engagement, and was that addressed around peers and the importance of as these resources were created?
So the resources are in draft form, so they're not fully baked, if I can say that. But yes, those things will be included. And also, as Anna had mentioned in the previous conversation around racial equity, we also included that information specifically in our draft recommended template that the counties will could use to submit their innovation projects. And these questions and ideas are included in that recommended template. So we have it in several different places. I also want to let you know that Kyle Doran is here on the line. If he's still there, he could probably speak to the question about peers. I did want to mention that we did have a special advisory group that included those with lived experience, youth, some commission staff, and other members of community-based organizations and other state agencies that were part of this work. And so we met probably 3 or 4 times to go over these recommendations, to go over the plan, to discuss the challenges and the barriers. So wanted to just lift that. And I don't know, again, I don't know if Kyle is on the line, if he could respond to that.
Yes, thank you. Oh. Can you hear me?
Yes. Yes.
Excellent, great. Thank you. Great to meet everyone. Kyle Doran, I'm a director with social finance. My pronouns are he, him, his. We did, over the course of our year-long research project, we made an effort to talk to as many people as possible and at the same time, we don't harbor any misrepresentations or misunderstandings, that we talk to everyone. So what we did do, and we'll let you all be the judge of whether, you know, of the degree to which we can improve that moving forward, and would welcome your feedback. But we had interviews with over 100 individuals, including those experts with lived experience, inclusive of some Access ambassadors as well. We had focus groups organized by both CAMPRO and NAMI, I think 2 or 3 focus groups each. And then we did have that recurring focus group or discussion group for the project that aimed to include individuals from different parts of the innovation ecosystem. And that group met 4 times over the course of our year-long project.
Thank you. Thank you, Sharmell. Thank you, Kyle. Appreciate that.
Yeah, actually, Chair, I also wanted to answer the second part of the question, which is very exciting too, is that since fiscal year 15-16, Commission has approved 187 innovation projects and authorized over $690 million in innovation work. So I did want to answer that question. Thank you.
I appreciate that. Thank you so much. Mariani, I think I have Stacy next. Is that who I see?
Yes.
Okay, please, Stacy.
Thank you. Once again, Stacy Hiramoto, REMCO, the Racial and Ethnic Mental Health Disparities Coalition. Pronouns she, her, hers. Again, thank you for the opportunity to make comment. And I want to acknowledge and thank the Commission for their efforts to improve the innovation component and process. I believe it's one of the most important things this Commission does. I know that counties do their best, but this is the most challenging component because they're supposed to be doing something that has not been done before, and it's very difficult to develop these. But I thought, and I was very happy, Chair, that you acknowledged and said the phrase, "nothing about us without us." And that's why I think it was good that Richard Gallo asked those questions about whether consumers were involved. Now, I don't proclaim to speak for all of these, but communities of color and the LGBT plus communities, as well as client and consumer communities, look to the innovation component as much as the PEI component of the MHSA for funding for people for their communities and doing programs that are respected and are effective with them. I think this is an example, when I think about it, where the Commission could put equity forward more. This project was given a sole source contract. The board and staff of social finance do not look to have a lot of diversity. Of course, you can't tell by looking whether they are from the LGBT community, but again, when I went to look at what they talk about this community, I didn't see very much except on their one page of the commitment to diversity, they do mention this. But I wanted to know why this, on what basis was this contract awarded? This contract could have gone to an organization that was led and founded by BIPOC or LGBTQ staff or consumer groups. This report does not touch on reducing disparities, equity, or even diversity. I realize there are many facets to innovations, and there was a lot of process questions on such as how to scale projects, how to make communications better. Yes, I realize that this report, was very broad and covered many things. However, again, given how much communities of color, the LGBT community, and other groups such as the client consumer community believe in and depend on are looking towards this component, I believe that some focus on equity and consumer empowerment should have been one of the major components of this project. And why is this project devoid of these considerations? And lastly, at the very least, I believe that the CLCC and the CFLC should have been involved with this project. Thank you.
Thank you, Stacy.
Next, we have Matt. Your line is open. You may go ahead.
Thank you. Good afternoon, commissioners and Toby. Matt Gallagher, Cal Voices, he, him, his. First and foremost, I want to thank the commission for talking about innovation. Since its rollout in 2012, I think it's been a common theme that innovation has underperformed and has not lived up to its expectation, or at least what the drafters of the MHSA hoped it would be. That said, we also need to consider and remember that the effectiveness of the innovation starts with the commission. We just heard data on how many the commission has approved, but what we don't know is how many commission hasn't approved. How many times have the commissioners sent the innovation plans back to the county and said, hey, this isn't innovative enough. We want to see better. We want to see more, and we want to expect more. Because ultimately, the bottom line starts with all of you. And one thing that has to be considered from the commission too is what kind of oversight are you doing once you approve the innovation plans? Are you having these counties and providers come back and provide updates, best strategies of what worked, what hasn't? What we saw with Help in Hand, for example, a program that was a failure, that we know was a failure, is documented as a failure. There was no follow-up. There was no oversight. There was nothing done from the commission after it was approved. It was almost as if the commission had washed its hands with the program because they approved it, they sent it on its way, and no follow-up was done. And last but certainly not least, when we look at the recommendations in the report, which is well drafted, and we do appreciate that, is that the commission should consider not a support group, but a standing advisory committee similar to the CFLC on innovation, and it should do so on prevention and early intervention. And that group should assist the commission in updating the annual regulations for prevention and early intervention, as well as innovation. And they should try to do that every 3 years, because that's really how we foster growth.
I've heard of other people saying they do.
I'm getting some feedback. And the very last comment I'll make too is we really need evaluation on this. We should know what the standard deviation is for failed innovation projects. We should know what works, what doesn't, and we should have some follow-up and reporting on that so counties know what to do and what not to do. And so far to date, in the last 10 years of innovation, we still do not have that. Thank you.
Thank you, Matt. This is something that I know we ask as commissioners, and I think we're moving in the right direction. I think this is a step towards it. Toby, I would ask if you could respond to that as far as where we're at with, this is one step in that direction, but if you could respond to some of those things that Matt brought up as far as, going back and following back up with our counties.
Happy to, Madam Chair. Thank you for the opportunity, and thank you, Matt, for the comments that you provided. There was a lot in what Matt shared. First, I want to just recognize that there was a moment in time where the innovation funds were flowing and we were not seeing investments. And during his public comment, Hector Ramirez made reference to the work the commission has done to publicly reveal information on the funds that counties receive, what they spend and what they have left unspent. And that information really revealed the significant balances of unspent innovation funds. Since that time, we've been working very assertively with counties and with community advocates and others to elevate the visibility of the innovation component. And we've seen dramatic increases in interest and the number of plans coming out of the community planning process. As was presented, I think 2 months ago, the commission has been investing in strategies to strengthen the community planning process around innovation, but more broadly, the entire Mental Health Services Act. What this report reflects is this evolution of that work from elevating awareness about the innovation opportunities, and that's reflected in the data that's in the dashboard that's in your packet today that shows the number of plans that have come into the commission, and it shows a very high level of approval, 90% or higher. What it doesn't show, to Matt's point, is the number of plans that have been withdrawn or revised as a result of the public review process or the commission's review process. And so that would be a much more nuanced story to tell, because a number of plans do come into the commission. They are subject to public review and comment, and as a result, they're either withdrawn or modified. over time. On this broader issue of how are we learning from and scaling effective interventions, the work that's in front of you is really reflective of those very challenges and our quest to really understand what those opportunities are and how we might pursue them. What we're seeing in this phase of the innovation component really is a shift away from individual one-off county innovations, although we still have many of those, but a shift toward this multi-county collaborative learning. And so the example from today was the electronic health records. We've had presentations on replicating the work that Solano did. I think we have 40 counties participating in a multi-county collaborative to replicate the tremendous improvements in community engagement through the Solano County innovation that was approved maybe 5 years ago. And then now it was approved last month, I believe, for other counties to replicate that. So we're in this phase where we've gone from little to no attention on innovation, greater attention on innovation, enforcing the expenditure requirements, counties getting engaged, to now trying to refine and strengthen opportunities to not just do an innovation, but to evaluate, to assess, and when effective, to scale. And so many of the projects here, many of the recommendations in this proposal really are about taking that next step to strengthen the evaluation, as Mr. Gallagher has pointed out, and to use that information to not just support an individual county's lessons learned, but to actually shape understanding statewide. And what we're also seeing is greater awareness of opportunities to leverage the lessons learned in the mental health space to even begin to shape some of the conversations that are happening with partners throughout the health and human service system, and even some other segments of our public sector agencies, such as in public safety and in education. And so this is a process, it is a dynamic and iterative process, and the proposals in front of you, the action items, really are about strengthening how we learn, how we share those learnings, and how we implement those learnings beyond the individual investments of a single county. That was a lot, but Matt gave us a very complicated question, and so I hope that answers many of the aspects of what he raised.
Thank you, Toby. I appreciate that. I see Steve. Am I correct, Amariani?
Yes, Steve, your line is open.
Please, Steve.
Thank you again. And I appreciate earlier Commissioner Madrigal-Weiss, you pointing out, because I went to Cal Mesa and I found a lot of information I didn't find it as easily on your own site, but I'll look harder. I think this would be a good opportunity, though, when you get presentations like this, to ask your presenters to include the links to circumvent a comment, and I will send an apology to the presenter, because it looks like it is available there. The only problem is, unless I go to Cal Mesa's website all the time, I don't know it's there, because there's no e-list that will send me an all meeting identifier list like you all have. I guess for me, innovation's really tricky because it's 5% of the budget and it takes an inordinate amount of time for the commission. So, and locally. So what I would ask is that you create forms that have all the details in them. Our presenters are used to presenting a story, but they leave out the adjectives, the adverbs, and the quantification. And that's distressing as a family member, because you don't know that if 45 people came to a meeting, you don't know that only 5 were for the community, because you're not asking and no one's telling you. So unless you specifically ask, the other thing is maybe you want to include, and it may be there already. I have to apologize. I'm sort of got the LA Mental Health Commission opposite this, so I'm sort of trying to go back and forth. That if scaling is what we're after, then let's have a provision on how this would scale. And it could be as simple as, you would think, Toby and the CBHDA get on the phone and everyone meets monthly and it's done. We believe it, it worked, we want to scale it, the money's available, it's a funding source, let's just get going. So the fact that it's not that easy speaks volumes to the community. And you know, I've gotten tons of resources. So and then I'll make last comment, though I know I say that a lot, so I apologize. Just remember, California, LA, Orange County, San Bernardino, and Riverside are 45% of California, America's 5th largest state. Even if I could coordinate the members that are on your board from those cities, and San Diego, I don't include it because it's not the same media market. So it's not TV, radio, and just 2 newspaper groups.
Steve, your time is up. If you could wrap up your comments.
Okay,
Thanks.
thank you. I will wrap up. Is that there's things that we could be leveraging that aren't even on the radar. So thank you again for letting me comment. I will send a note to the Cal Voices lady and Carbon, Toby, and the commission. Thank you.
Thank you, Steve. Mariana, I see Anna.
Yes, Anna, your line is open. You may go ahead.
Thank you so much. I see this improvement project as a step in the right direction. I also want to second everything that's been said before me, especially by Stacy and Matt. And I also want to point out 2 things. When you're approving innovation projects, please make sure you encourage counties prioritize peer-run programs. And what I mean by that is peer-run programs run by people with direct lived experience. If you want us to get better, you need to give us responsibility and allow us to be independent. It's crucial. I don't need to explain why. And the other thing, as you're involving us in developing priorities and developing these projects, as you involve peers, please, again, make sure that the voice of people with direct lived experience has more weight, and family members, forgive me, than the family member voice. And I explain why. We are the people who are receiving these services. We are the people who are being locked up if we're not doing well. And so we need to be heard first. And so we also need to make sure that community is educated and knows how to provide that input and where. So if there is an innovation project that you're going to be approving in the future, or if you're going to be doing a research with the counties on that, please take a look at that, how the counties are helping us get involved correctly. Thank you so much.
Thank you, Anna. All right. If at this time, I would invite any of my fellow commissioners to make any other comments regarding this. If I see none, all right, then we will move on. So it is 12:22, and I believe we have come to the end of the agenda. Am I correct in this, team? Toby?
Yes.
That's correct.
Yes,
Wow.
Madam Chair, correct.
All right, looks like we have. So I want to thank everyone for joining us today and to continue to work and discuss around mental health. We want to especially thank members of the public. We absolutely value your input and participation. Our next commission meeting will take place on November 17th, and we look forward to seeing everyone next month. With that, be safe out there. Take care of yourselves. We will see you on November 17th. Take good care. This meeting is adjourned. Take care. Turn off the mic in the office, everyone. Bye-bye.